All right, good morning, good afternoon, or good evening, wherever you're logging on from. Welcome to the July version of the Australasian Pleural Seminar. Today, it's my great pleasure and great honor to have Professor David Feller-Kopman to join us. David needs no introduction. He's the godfather-like figure in interventional pulmonary in the United States, and he's well recognized as one of the pioneers many years ago to start the subdivision or subspecialty. He's recently moved to Dartmouth in New Hampshire, but he remains a very strong advocate for pleural manometry, which is obviously a very controversial topic in pleural disease, and there are disbelievers like me. So David is going to spend the next 15 minutes to try to convince us that it is a very useful thing. As always, please put all your questions on the chat as we go along. And the floor is yours, David.
Excellent. Thank you so much for the invitation. I thought I'd take a little bit of a look back in manometry and also potentially where we're going forward here. The only disclosure that I have is I'm a section editor for Up to Date, and also that it's 1 o'clock in the morning my time. Now, despite what Gary says, he actually does love pleural manometry. It's a total game changer. And I want to talk to you a little bit about why that is. So in order to understand the benefits of manometry, we need to think about anatomy a little bit, and then also some physiology, how we could potentially use manometry to understand our patient's physiology, both in terms of pleural effusions, pleurodesis, as well as pneumothorax. So as everybody knows, the lungs are lined by the visceral pleura, the chest wall by the parietal pleura, they merge at the hilum, and if you take your lungs out of your chest wall and put them on the table, they will collapse. And if I open up my chest is going to expand. And that's balance of forces there keeps my pleural pressure slightly negative at functional residual capacity. We don't really know why we have a pleural space. Some people teleologically postulate that having a negative pleural pressure, FRC, prevents atelectasis with every breath. Because if my pleural pressure is -3, my alveolar pressure is 0, my transpulmonary pressure is +3 at the end of a normal respiration. Now, elephants, for example, don't have a pleural space. They do just fine. And there are these two nice papers by John West talking about the snorkeling elephant. The elephant, as they're crossing the river, are submerged about 2 meters. And in order to breathe, they would need to generate about 150 millimeters of mercury pressure in their pleural space, which would rupture pleural capillaries, cause pulmonary edema, and very similar to the sheep and humans, whereas we have a very thin parietal pleura, elephants on the right have a layer of loose connective tissue, dense connective tissue, and alveoli. So large mammals can function without a pleural space, and we'll get into some pleurodesis literature in a little bit. So we don't really need a pleural space. We're not really sure why we have it teleologically. Another comparative anatomy thing that I like to think about is the North American bison or the buffalo. And the Native Americans were able to take advantage of this in that shooting one arrow into the thorax, which is just a very small part of the animal's chest, very close to the head, they would induce a bilateral pneumothorax. And there's this really nice paper by Blacha in 2021 where they actually went to the Western United States, worked with one of the veterinarians who just wrote about this, and then did autopsies on these North American bison and actually visualized the pleural defects that are labeled as number 5 in there. So some neat comparative animal physiology between elephants, North American bison, and humans. Now, we all understand that when we develop pleural effusions, that causes dyspnea, and it is not due to low oxygen levels. It's not due to changes in lung mechanics like low FRC, changes in TLC. It's actually due to the inability to generate negative pleural pressure at all lung volumes. So Esteen did this where by inducing pleural effusion, the graph on the left, you could see that at any given lung volume, pre and post thoracentesis, you were able to generate significantly greater negative pleural pressure. And this is all due to the length tension relationship of the diaphragm. That's the difference between C and C prime on the graph on the right, before and after thoracentesis. So more recently, this group looked at diaphragmatic excursion as well as velocity of contraction with M-mode ultrasound before and after thoracentesis. And both of these improved in patients who had expandable lung, but not in those with non-expandable lung. And they postulated that it's the negative pleural pressure in the chest that would restrict diaphragm motion in those with non-expandable lung. Now, they didn't assess the degree of curvature or pleural pressure, but it does raise the possibility that the negative pleural pressure is part of what's causing this non-expandable lung and diaphragmatic inefficiency. So I think that's an area of future research there. Now, one would think that if you add fluid to a chest cavity, the pressure would rise, but it actually is dependent on the cause of the effusion. And it tends to be more positive in cases of vascular leak or elevated hydrostatic or oncotic pressure, and tends to be more negative in patients with atelectasis or trapped lung. So getting into a little bit of history on this, this is not a new concept. Stephen Hales was an English physician who performed animal experiments by connecting a manometer filled with wine to the pleural space and looked at what changes occurred during respiration. And then James Carson, who is a Scottish physician about almost a century later, took the trachea of animals and submerged it underwater and looked what happened when the thorax was opened. And Carson was actually known for creating the therapeutic pneumothorax to treat TB, which in turn was the original model for trapped lung. So this is the Davidson pneumothorax apparatus. I have this in my office, actually. I bought this online for about $200. And this is a machine that was used in the 1930s to induce pneumothorax. And what I love about it is if you look at the instruction manual here, it says there are many types of these apparatus for inducing the pneumothorax, and the success of treatment depends on the physician, not the apparatus, and the choice of the patient, of course, is most important. But if you look at the details in there, it says brandy and other stimulants should be at hand in case of accidents, but the patient should not see them. So clearly these were meant for the treating physician and not the patient. Now, as we remove fluid from a closed chest cavity, one would expect the pressure to drop. And there are benefits of removing as much fluid as possible. Clearly, we want to maximize the patient's symptomatic relief. We want to minimize repeat procedures. So if a patient has 2 liters in their chest, it doesn't really make sense to only take out 500. And then it could potentially aid other diagnostic tests, and perhaps most importantly in malignant cases or recurrent, even non-malignant effusions, is predicting the success of pleurodesis. So it would be impossible to know if somebody who has 2.5 liters in their chest is going to pleurodese if you only take out 500. But we want to do that safely, right? So Rich Light, who I think was a huge mentor to Gary and many of us interested in the pleura, looked at this in 1980, and he wanted to understand the diagnostic usefulness of pleural manometry and the safety in removing large volumes of effusion. So he looked at 52 patients and measured pleural pressure every 200 cc's until either the pleural pressure dropped to less than 20 centimeters of water, there was no more fluid, or patients developed symptoms of chest pain, cough, or dyspnea. And this is the apparatus that he used. It was an Abrams needle connected to a U-shaped manometer. What he found is there was a big variation in initial pleural pressure. Transidates tended to have both positive and negative opening pleural pressure. Hepatic hydrothorax, more positive than heart failure. Malignant effusions tended to be 0, and if the opening pressure was less than 5, patients either had cancer or trapped lung. So it was potentially diagnostically useful. What he stated in this paper is that if you aren't measuring pleural pressure, you should limit the thoracentesis to 1,500 mLs, which has since perpetuated into sort of lore. There's really no data necessarily that you need to stop. And he defined 3 distinct pleural pressure curves. So the top open circle is where it starts out positive. He was able to drain 3.5 liters, and it ended up physiologic, -3, -5. The black circles started out positive, and then towards the terminal part of the thoracentesis, the pleural pressure fell. And then 2 curves on the left started out negative and dropped precipitously. And this gets into the whole concept of non-expandable lung, which is really an umbrella term thinking about the 2 types of non-expandable lung, which are lung entrapment and trapped lung. In lung entrapment, the underlying disease causes the effusion, such that there's active pleural inflammation, there's visceral pleural encasement, or increased elastic recoil pressure of the lung, or endobronchial obstruction, meaning that as you drain out the fluid, the lung is not going to be able to expand due to one and or more of those etiologies. In trapped lung, on the other hand, it's old pleural inflammation. These are the patients who have maybe had a post-cabbage effusion, and you develop visceral pleural thickening. And it's the negative pleural pressure that actually causes the effusion. So the way to sort of think about this is that trapped lung is a pleural effusion ex vacuo. It's the negative pressure there that's drawing in the fluid. That fluid tends to be transitive. The patients are typically asymptomatic, so you don't need to treat them. Lung entrapment, or entrapped lung, on the other hand, is active pleural inflammation. Those are exudative effusions, and you either need to treat what is causing that exudative process, be it endobronchial obstruction or malignant pleural effusion, or proceed with decortication to really get rid of that fluid. And then looking back at Dr. Light's curves, this is what he defined. So normal lung entrapment and trapped lung. And again, I like to think of entrapped and trapped as more of non-expandable lung. So Salamonson recently, well, actually not recently, in 2014, used ultrasound to identify non-expandable lung because we want to be able to identify patients with non-expandable lung before subjecting them to pleurodesis. We also don't necessarily want that call from radiology after a thoracentesis that there's a pneumothorax. We know that air will get into the pleural space. I call that the milk bottle phenomenon. As you pour milk out of a bottle, air has to go in if the pressure in the chest is dropping, right? And this is just an example of 2 patients. The X-ray shows a left ex vacuo pneumothorax, and the CT on the right shows a right-sided ex vacuo pneumothorax. And the CT on the right is very helpful because it actually shows the thickened visceral pleura. There's no way that his lung is expanding without decortication. And the group from Medical University of South Carolina actually uses manometry during thoracentesis. If the pressure is dropping too much and patients are developing chest pain, they will entrain air into the pleural space, let the pleural pressure rise, send the patient for a CAT scan, which they call an air contrast CT. And that actually, again, shows the thickened visceral pleura. So it's diagnostically useful. So Lan in 1997 said, hey, how about using manometry to identify expandable lung and see if patients will have better outcomes with pleurodesis. So this is the setup that they used, which was basically like a lumbar puncture kit. And they actually only drained 500 mLs. So they did not do a full thoracentesis. They were sort of looking at the elastance of the pleural space in the first 500 mLs. And I just abbreviated that as elastance of the pleural space in the first half liter. And it tended to be higher in the trapped group than the non-trapped group. But pleurodesis was unsuccessful in everybody in the trapped lung group, and this is their terminology. We know that it's probably entrapped, and 3 patients without trapped lung, but who had a high pleural elastance greater than 19 centimeters of water, as opposed to patients who had a low pleural elastance, meaning the delta volume over delta pressure. Pleurodesis was successful in 98% of those. Martin published early results from what is called the pre-edit trial, which is using the digital manometer to select patients for either IPC or talc slurry pleurodesis. So we're waiting results from that larger trial. So some more recent data. This is a paper that came out in 22, the association between terminal elastance. So unlike Lang, where they looked at elastance in the first half liter, this group looked over elastance in the final 200 mLs. And there was a lot of variation between radiographic lung re-expansion by either chest X-ray or ultrasound, which was present in the large majority of people, versus manometry, which they deemed visceral pleural recoil, which is basically pleural elastance. And that was quite abnormal in the majority of patients who expanded. So you could see that there's a discordance here between radiology and physiology. The sensitivity, specificity, and positive predictive value of radiographic lung re-expansion with normal pleural elastance was less than 50%, basically. So we really should not necessarily be using radiology to assess pleurodesis success. So even if you do a thoracentesis and the lung looks like it's going to expand, if there is high pleural elastance, that patient might fail pleurodesis. So it might be more important to measure pressures. Likewise, this was a paper of 70 patients undergoing thoracentesis. Elevated pleural elastance was found in more than half of them, whereas incomplete lung expansion was also found in more than half of them by chest X-ray, and about 30% had discordance. So some patients have complete lung re-expansion on X-ray, but high pleural elastance in about a third, and likewise patients without complete lung expansion on X-ray have normal pleural elastance. So we need to do some future work in understanding the relationship between pleural pressure and radiographic lung re-expansion. This is a paper that we did about 20 years ago now, where we tried to correlate pressure with symptomatic changes. And chest discomfort, this vague sense of chest discomfort, actually correlated quite well with dropping pleural pressure. Patients with cough actually did not have any correlation with pleural pressure, opening pressure, closing pressure, or change. And the theory was that cough is actually resolution of atelectasis caused by the effusion. We subsequently looked at 185 patients with large volume thoracentesis looking for the risk of re-expansion pulmonary edema, which is really rarely seen. I call this the Sasquatch of chest medicine. That being said, when it does happen, it's associated with high morbidity. So one question is, can pleural manometry help prevent this? And just in terms of incidence, in 185 patients, the incidence of clinical RPE was only 0.54%. So clinical and radiographic RPE was not associated at all with opening pressure, closing pressure, change in pressure, or pleural elastance. So getting back to Light's original paper, I think there are benefits of draining more than a liter and a half, and we don't necessarily need to fear RPE as much. So how about complications? Can these be avoided by measuring pleural pressure? Two papers, one by Jay Heidecker and one Rob Lentz more recently looked at this. In the Heidecker paper, there were 8 pneumothoraces. All of them they felt were due to non-expandable lung. 4 of those had high pleural elastance. And then more recently in Lancet Respiratory Medicine, 124 patients randomized to thoras with or without manometry. There was no difference in chest discomfort. However, interestingly, there was a 10% pneumothorax rate in the control group and no pneumothorax in the manometry group. And I think one of the big caveats of this study in terms of manometry preventing chest pain is that the mean volume drained was around 1 liter. So we really don't know if manometry can prevent chest pain when we're doing larger volume thoracentesis. And that's another area of research that I think would actually be quite interesting. And then this was a randomized trial that was published in 2023 in patients with large malignant effusions, and manometry actually was associated with more volume removed, almost twice as much, and more congestive symptoms, that meaning that patients had a little bit of a cough afterwards. But again, manometry allows us potentially to drain more volume safely. I think it's important to think about pleural pressure as we're draining patients. If you hook somebody up to a vacuum bottle, it starts out at negative 900 centimeters of water pressure. If you use a 60 ml Luer-Lock syringe, you could generate 800 centimeters of water pressure. And then wall suction, you can see in gravity. So Rob Lentz again did a multicenter RCT of aspiration versus gravity, and there was no difference in chest discomfort, dyspnea, or the mean volume drained. Gravity took about 7 minutes longer. So I'm not sure pressure helps in terms of draining, except if you don't use pressure and you just use gravity, it's going to take you a little bit longer. Now, there are a couple of ways to measure manometry. You could use what Rich Light used. You could use what Land did. You could use this quote unquote bedside poor man's manometer. And you could use a digital manometer. So the one on the left is one that you could hook up to ICU transducers and you get a respirophasic variation looking at end inspiration and expiratory pressures. And then the compass manometer on the right. Peter Dolkin showed that the digital manometer has a near linear relationship with the water manometer. And then Hans Lee was the lead author on this study that we showed that the poor man's U manometer doesn't correlate nearly as well compared to the electronic transducers, but the little compass digital manometer is quite accurate. So what could there are pros and cons. The pros of manometry, I think, is that it guides safe fluid removal, predicts lung expansion, gives you some diagnostic value and physiologic insight. And then perhaps most important clinically is that it could help predict pleurodesis success. Now, some of the cons are that it could add a little time or complexity. Maybe interpretation can be challenging, which I would disagree with. Not always available. I would pretty much disagree with that. So I do think it informs our decision on how much volume we can remove. Is the lung likely to expand? Is pleurodesis going to be successful? And what's the underlying cause of the effusion? Some of the rebuttals, again, are that there are no outcomes data. Well, maybe. I do think the outcomes for pleurodesis success are legitimate. I think that if we look at the incidence of pneumothorax, it tends to be much lower in the manometry groups. And then some people say, well, you could drain all the fluid without manometry. And yes, that's true. Those symptoms alone miss a significant percentage of patients with non-expandable lung. And I don't think manometry is like the Swan-Ganz catheter. There's no data to suggest that misinterpretation of pleural pressure occurs. It's actually quite easy to do. No data to suggest that misinterpretation leads to inappropriate clinical decisions, and it's quick and it's easy. So I just wanted to end with a couple of slides on pneumothorax. This is a paper that Ardi and Latifi was the lead author on, where we looked at pleural pressure in cases of pneumothorax. So this was a multi-center prospective observational study of 37 patients, 9 of whom had tension, either physiologic or radiographic tension pneumothorax. And the patients with tension had higher inspiratory as well as expiratory pleural pressure. And the greater inspiratory pleural pressure was associated with a significant increased risk of both radiographic and hemodynamic tension. And that makes sense. That is something that has been postulated about for years, that tension is defined by positive pressure during the respiratory cycle, but it was really never measured. So kudos to Dr. Latifi for taking this study through. And then Amit Chopra has done some very nice work on drainage-dependent air leaks. So here he looked at 22 patients with a persistent air leak and looked at pleural manometry. And you could see that if their baseline pleural pressure, then there's a cough. And then if it returns to baseline, that is consistent with a drainage-dependent air leak, meaning that the only reason the patient is having an air leak is because we're putting suction on the tube. And that's different from a drainage-independent air leak, where if you clamp the tube, the pleural pressure continuously rises. And these drainage-independent air leaks are associated with longer hospital admissions and higher need for surgical re-exploration. So performing manometry in patients with pneumothorax could actually help us think about these patients differently. The patients with a drainage-dependent air leak, take the tube out. Patients with a drainage-independent air leak are the ones that we're going to need to intervene on. So it's one of these guess what moments when I think about manometry, is that it's actually not hard. It could actually help us. But I do think we need to think about future studies that need to be done. I think pleural manometry helps us understand the physiology of the pleural space and the underlying disease, and can guide complete drainage, can differentiate lung entrapment and trapped lung, and assess patients for pleurodesis. It doesn't prevent pain with thoracentesis if you're draining less than a liter. We don't know about more than a liter. And I think it definitely improves our understanding of drainage-dependent air leaks. So with that, I thank you for your attention. I'd be happy to take any questions.
Excellent. Thank you so much. This is by far the most comprehensive and also the most digestible and enjoyable lecture I've ever been to on pleural manometry. Thank you, David.
Thanks,
So
Ken.
while people are writing the questions, let me just ask you, so there are many different types of manometry. You shows that it probably doesn't make a lot of difference. But would you prefer one over the other?
So the nice thing about the U-shaped, or what I call the poor man's manometer, is that you can just do it with a thoracentesis. And at the bedside, I'm not looking for exact numbers. I'm just looking for a trend in elastance. So by me taking the syringe off and gauging where it is in relation to the catheter insertion site, I could see if it starts out positive and then is dropping quickly. So I think we need to figure that out clinically, what method is best to use clinically. We know it doesn't correlate as well as the digital ones, but that might be good enough.
And is it true that I've always been taught that if the patient then coughs halfway through, then you're zeroing your calibration of the manometer will go haywire and you can't really use the readings afterwards?
Not necessarily. I think it depends on what type of manometer you're using. Clearly, if the patient coughs, probably because of atelectasis going away, the lung re-expanding, the pressure is actually higher than it was before. So that's something that we see often. And again, I'm not saying I use manometry at every single thoracentesis, but I do think it's interesting to think about. I like thinking physiology stuff.
Okay, so the online question is, thanks for a super interesting talk. What influence does the patient position have on manometry, and can we do it lying down?
Yeah, absolutely. You could do it lying down. The pressure that you're measuring is the pressure at skin insertion site. So if you could imagine, if this is a lateral view of the thorax, I don't even know how to do that. Let's just say this is the thorax. So if my um, thoracentesis catheter goes in up here, clearly it's not going to be as affected by the fluid above it, right? As if my thoracentesis catheter goes up in over here. There's more hydrostatic pressure above. And that hydrostatic pressure above is going to be smaller and smaller as I drain that fluid. Does that make sense?
Hmm.
So we tend to put our catheters in more dependently, right? Because that's where more fluid is, as opposed to putting it up here where there may only be a thin rim of pleural fluid, right? So there is some artifact involved in the measurements. That being said, the pressure you're measuring is the pressure at that site. So whether you're supine or in any position, it doesn't necessarily matter. But I do think it is important to think about that hydrostatic column above the catheter.
And the volume that you check that you take the reading, the volume of fluid you drained before you check the manometry reading, quite variable amongst papers. It's 200,
Yeah,
250,
that's right.
500.
I think 240 is a common volume just because that's 4 pumps of a 60 ml syringe. Um, but you could check it whenever. And again, I'm typically just using it as a gross estimate of pleural elastance. Is my pressure dropping every time I measure it? Then I might check it more frequently. In patients with hepatic hydrothorax, for example, I could check it every 500, or a liter or so.
And another question online. Great talk. Does the type of tube, whether you use a big bore tube or pigtail, or the length of the tube influence the manometry reading?
It doesn't. I haven't seen any papers that suggest it would. The pressure is the pressure along the tube. The resistance of a longer tube is higher. So as you're withdrawing fluid, the resistance can be higher. But the pressure should be uniform, especially since you're sort of measuring it at a static point in time.
All right. Professor Lam from Hong Kong. May I ask if and how the manometry will be affected by viscosity of the fluid, and also the compliance of the adjacent lung?
Well, the viscosity part, I'm not sure it would affect. And we measure the pressure in air as well. So air is certainly less viscous than pus, and both give adequate pressure measurements. Now, the compliance of the lung is actually what we're measuring, right? So if you have underlying non-compliant lung, that will definitely affect pleural elastance and the lungs' ability to expand. And this has been looked at in the ICU, for example, and the benefits of draining pleural effusions in the ICU. The benefit in PF ratio actually has to do with your end expiratory lung volume. So if you have a dense socked-in pneumonia or ARDS and a big pleural effusion, as you drain that effusion, that lung is not going to expand. You're not going to get any improvement in your PF ratio, for example. Whereas if you have a more compliant lung and you drain the pleural fluid, the lung expands, your PF ratio could actually significantly improve.
Well, that pretty much answer or partially answers the next question, which is an ICU question from Ed Fish, and say, thanks, David. Is positive pressure ventilation with perfusion patients, can manometry help to determine to what degree is atelectasis as opposed to other causes of the effusion, and can it help to titrate PEEP?
Yeah, so that's a great question. We don't know about PEEP titration. That's something that I'm actually quite interested in. Is could we, the at least 40% of patients in our ICUs have pleural effusions. So we could easily get a catheter in there. And there's a lot of work being done at PEEP titration using esophageal manometry, right, to look at transpulmonary pressure because we ideally want to set PEEP to a level that will keep the alveoli open at the end of exhalation, especially in America where we have an obesity problem. So a lot of the pressures that we're measuring on the ventilator from the respiratory system are not due to the lung, it's the chest wall and the obesity. So in those patients, guiding PEEP by esophageal manometry is a study that's being done right now. BI is the lead center. It's called the Prevent Villi trial. So they're basically measuring esophageal pressure through a nasogastric tube. We could easily look at pleural pressure through a pleural catheter as well. So I think that would be very interesting.
And one more question is from Chin, who says about loculated fluid. Does loculated fluid
Yeah,
alter manometry?
I think it would. You know, Naj Rahman has a really lovely picture when he's talking about pleural infection, and he's sampling the pH in two adjacent locules, and they're quite different. So I could imagine that the pressure could be different in those as well. I think it's probably going to be dependent on what's going on with the adjacent lung.
Yeah. Okay. Excellent. And I was quite curious when I was reading the chest paper about the tension pneumothorax. How do you have time to go and measure manometry and all these kinds?
Yeah, so that's a great question. So basically, we used a digital manometer and we put it in line with the introducer needle. So it literally took 4 breaths, right? So even in patients who were hypotensive, it took 4 breaths. We video recorded it and then took the manometer off, put the guide wire in, and we were able to measure it. So.
Yeah.
And it got through the IRB because of the minimal impact on the patient.
Amazing to have it done. Well done. Okay, so I think we're a bit over time, and one more question. We'll allow that last one. How do you do that with blunt dissection big bore tubes?
Well, so I can't think of a way to hook up a manometer. However, um, I'm sure everybody who's put in a large bore tube, fluids either coming out or what often happens is there's a fluid column and the patient takes a breath and the patient sucks in all this air, right? That's because they have negative pleural pressure in there. So
Oh,
despite having a large effusion, they may get a pneumothorax on that x-ray, which is atmospheric pneumothorax. It's no big deal. But that's why whenever I'm hooking up a chest tube to suction, I'll have the patient cough. Just push out some fluid, get a bigger water column. But you can see them with a large bore tube and an atrium or oasis or whatever closed drainage system that you use. You see that pleural pressure variation all the time.
but practically, do you need to use the
Yeah,
YouTube?
practically it's a little bit harder. Yeah, I'm not sure. You might have to do, so Peter Dolkin has this thing in one of his papers where he uses a damped manometer. So he takes a 19 gauge needle and sticks it into the tubing. Um, I could try to get that reference for the chat.
Okay. Excellent. All right, we're well over time, so that just shows us how much interest this is in the topic. Thank you so much, David, especially at 1 o'clock at your time. Let's join me, at least, to thank David for a marvelous lecture. And then join us next month. We will have Kevin Blythe to talk about MRI in pleural disease. See you next time. Thank you. Bye.
Excellent. Thanks so much for the invitation.
Thank you.